Muting.
Good afternoon. Can you hear me and can you see my slides?
Yes, sir, we can hear you.
Okay. Okay, right. So let's talk about dengue in this CLD. Well, although it's called a clinical lecture demonstration, it's more like a lecture really, because frankly, we don't get much of a chance to give you medicine lectures. So we make use of this opportunity to try to teach what we would like to teach you in a lecture. So basically, so what I do is I'll first go inside. Right. But I go to the pathogenesis very briefly, and then get on to clinical management and briefly discuss some cases. So with regard to pathogenesis, basically in the human being, the dengue virus replicates in mononuclear phagocytic cells, especially blood monocytes, which helps to maintain the viremia. So they are not destroyed by these monocytes. They actually live inside the monocytes and replicate inside the monocytes. And therefore, by doing that, they maintain their viremia. And the infection is brought under control by the formation of antibodies, which are called neutralizing antibodies or blocking antibodies. The antibodies function varies with the antibody titer. Now, when the titer is very high, it has the blocking effect, which I told you about, and therefore it produces type-specific immunity. Now, what I mean by type-specific immunity is that the dengue virus has four serotypes, called dengue 1 to dengue 4. Some people believe that there's a fifth serotype also, but that is not well established yet. So den 1, den 2, den 3, den 4, that's how they are named. So let's say, for example, you get a den 2 infection, and when the den 2 antibodies are in high titer, it will be giving type-specific immunity. So it is giving you immunity against den 2, but not against the other three serotypes. Now, this sort of high titer is maintained in the first several months after infection by that particular serotype. But thereafter, the titer falls to a medium level, and then there is no blocking effect on even den 2. But more importantly, it also has a type non-specific enhancement of viral entry into monocytes. What that means is, let's say you got den 2 infection, and then that means soon after the infection, you have a very high titer of antibodies, and therefore they have den 2 immunity against further den 2 infections. But a few months later, the titer falls to a medium level, and then if you get an infection by den 2, you might or might not get any protection. But the dangerous thing is that if you get an infection by DEN 1 or DEN 3 or DEN 4, then those antibodies actually promote the entry of those viruses into the monocytes. Therefore, it promotes the growth of the virus also, because as I told you earlier, the virus grows inside the monocyte. That's called, that gives rise to a higher viremia. That's called antibody-dependent enhancement. So this lasts for a few years after the first infection. Therefore, secondary infection by another serotype will cause a higher viremia, and which is actually dangerous. Now, the same sort of thing happens to the newborn baby also, because as you know, when babies are born, they carry IgG antibodies from their mothers. And if the mother has had a very high titer of the dengue antibodies during the latter part of the pregnancy, she would have transferred some of the IgG antibodies to the baby also. And the baby might be having medium level titers. And if the infant baby gets infected by this a different serotype during infancy, the first few months of infancy, then also in the infant, this antibody-dependent enhancement or ADE will take place, giving rise to a higher viremia. And it is this higher viremia that happens in this way that gives rise to what's called dengue hemorrhagic fever, dengue shock syndrome, and so on. Now, after a few years, the titer falls further, giving rise to a lower titer, and thereafter there is no effect. There is no immunity as well as no antibody-dependent enhancement. So it occurs several years after infection. Now you can understand our problem. Now we are living in an area which is endemic for dengue. So we always get infected by dengue every year, basically. So therefore, if by some chance we get a second serotype infection, while the first serotype's blocking antibodies are present at a medium level, we run the risk of getting this antibody-dependent enhancement and therefore getting dengue shock syndrome or dengue hemorrhagic fever. Now, continuing with the viremia, now during the viremia, the body produces cytokines to bring it under control. And of course, there is a interest in trying to figure out if we could use, if it is possible to use markers of cytokines, such as the genetic markers or immune markers or even cellular markers, to be used in the diagnosis and prognosis. Because if we can determine the cytokine level in the very early stages of infection, that means we can also predict whether the patient is going into dengue hemorrhagic fever or dengue shock syndrome before the patient goes into that state, because it's determined by the cytokine level. But unfortunately, so far, of course, we don't have an adequate marker which might help us to predict that. That's an important thing, because like every dengue patient, we have to admit to hospital to observe in case they get a dengue hemorrhagic fever. So that's a very difficult thing to do for both the patient as well as the healthcare sector. If there's some way that we can predict which ones are going to dengue hemorrhagic fever and which ones are not, then we can limit the number of admissions of those dengue patients and also limit the burden on healthcare staff to monitor them. That's the reason why there's interest in the possibility that we might be able to check cytokine levels using various markers and therefore predicting whether a given patient will go into dengue shock syndrome or not. Now, as I said, there is the higher viremia, which is caused by the antibody-dependent enhancement, gives rise to what's called a cytokine storm, because it's a huge amount of cytokine release because of the huge viremia. And that gives rise to a sudden but transient increase in capillary permeability for fluid and less so for albumin. So the fluid leaks out. Remember, this increase in capillary permeability is a functional increase. What that means is there is no structural change. Now, if a dengue patient dies and we do a post-mortem examination, if we do a histological examination of the capillary bed, you will find that the capillaries look histologically normal. So there's no damage to capillaries in a cellular level. This is a functional permeability, which is also the reason why the leakage is very transient. It can reverse very quickly because, as you can imagine, if there's a structural damage, it will take longer to reverse. But with a normal structure preservation, if there's only a functional damage, then it can reverse to normality very quickly. That's why this leakage is very transient. Now, as a consequence of the leakage, the fluid leaks into interstitial spaces and serosal cavities, such as the pleural space causing pleural effusions and the peritoneum causing ascites. In the early stages, it produces fluid to collect around the gallbladder and in the Morrison's pouch in the pelvis. In the next stage, they get a right-sided pleural effusion. Then in later stages, if there's further leakage, they can get bilateral pleural effusions as well as ascites. That usually happens if the patient has been given IV fluids. If the patient has not been given IV fluids, it's very unusual to see bilateral pleural effusions or ascites. It's possible, but it's not, especially large effusions or large ascites is certainly associated with fluid therapy, IV fluid therapy. In the very later stages, the patient can also develop pericardial effusions, usually due to excess IV fluid therapy or what we call overload. So the degree of leakage can vary from a very mild amount of leakage, such as when you see only fluid around the gallbladder and Morrison's pouch, to a reasonable level where they may have right-sided pleural effusion, to an even more leakage, especially if you give IV fluids, giving rise to bilateral effusions or ascites, and even further effusions if you give volume overload, that's when you get pericardial effusion. So one manifestation of this increased capillary fluid leak is collection of fluids in interstitial spaces and serosal cavities. The second manifestation is they become hypovolemic because, as you can understand, the plasma leaks out, therefore the total blood volume becomes reduced. And that is the reason for the death, because they die of hypovolemic shock. But the hypovolemia is not due to hemorrhage, but it's due to plasma leakage. So as a result of hypovolemia, you will get clinical features such as reduced blood pressure, increased pulse rate and heart rate, increased capillary refill time, and reduced urine output. If we have ultrasound scan facilities, we can also look at the inferior vena cava to get an idea about the volume status. The next consequence of this fluid leakage is hemoconcentration, because you can understand when there's a certain blood volume and the plasma leaks out, the proportion of red cells is now increased. Therefore, when you take a blood sample, although the patient is hypovolemic, the blood is now hemoconcentrated. So that can be seen as either an increase in PEC cell volume or an increase in serum cholesterol compared to baseline levels. And of course, when there's enough hypovolemia, the patient will develop circulatory shock. Did you understand that part, that pathogenesis part? Do you want to ask any questions? Because when you understand this only, you can know how to manage patients clinically.
So, if there is a reinfection from the same serotype, will the antibodies be high in the second infection or in the medium level?
So it'll probably be higher. That is the normal way with all immune responses. But if it's the same serotype, they say it doesn't produce this antibody-dependent enhancement. That must be from a different serotype.
Is it possible to get infected by two serotypes at the same time?
Of course, yes. There can be co-circulation of dengue serotypes in the same epidemic. Normally, if you take a dengue epidemic, from year to year, there's a predominant serotype like dengue 2 or dengue 3 and so on. But of course, it's quite possible to have co-dominance as well. Usually, we see one predominant serotype. I think once or twice they were talking about co-dominance. I mean, all the serotypes are always present in the epidemic, but one is dominant. The others are like present in very small amounts. There aren't many studies done locally to look at this pattern. I mean, basically, what has been done is very small amounts of samples, like about 50 people and so on, and try to see which serotypes are present mostly. So you can understand during an epidemic, just having a sample of 50 or something is not enough to really comment about the full epidemic. But generally, it is believed that there is a dominant serotype in every epidemic. And as you pointed out, sometimes you can have two dominant serotypes also, almost equally dominant serotypes also.
Well, thank you.
So does having dengue with one serotype provide lifelong immunity for that specific serotype, sir?
Not lifelong immunity, no. No, it doesn't last that long. You can get reinfected with the same serotype years later.
Thank you, sir.
You can, of course, will get a better antibody response the second time, but many years later, you won't get the antibody-dependent enhancement. Okay. But the immunity for that particular serotype is fairly good there, in the sense like, if you have been already infected by all four serotypes in the past, then very likely your chance of getting another fifth dengue infection, clinical infection is very small. And also your chance of getting dengue hemorrhagic fever will also be very small, provided the levels are, very low, not in the medium level. So, I mean, there's a general belief that you don't get dengue more than about 2 or 3 times, but, it's possible, but generally it's believed that you don't get it more than about 2 or 3 times. But certainly the second time and third time are very dangerous because of the possibility of antibody-dependent enhancement. Okay, let's get on to the other features. Now, another important feature is thrombocytopenia, as you very well know. This happens due to 2 reasons, 2 effects. One is the reduced thrombopoiesis in the bone marrow due to the virus. And, like during recovery, this reverses. And when it reverses, you find that giant platelets appear in the peripheral blood picture. So that's a very good sign when you find giant platelets in the peripheral blood picture. That basically means that your bone marrow is recovering from the reduced thrombopoiesis. The second reason for thrombocytopenia is peripheral platelet destruction, which is believed to be due to antibody-mediated destruction. Now, the important point is the thrombocytopenia generally parallels the cytokine response. Basically speaking, as the cytokine response happens, the platelet count also drops. The reason for that is both of them are due to the same reason. Both of them are immune responses to the viremia. So on the one hand, it reduces platelet formation and increases platelet destruction. On the other hand, it produces the cytokine storm. So they go parallel. Therefore, you can look at the platelet count and decide whether the cytokine storm is getting worse. When the count is dropping, that means the cytokine response is taking place. When the platelet count is increasing again, that means the cytokine response has finished. So the danger period is when the platelet count is dropping, especially dropping quickly. Now, if there is a plasma leakage, the platelet count is always less than 100,000. In other words, if it is above 100,000, the cytokine response is not yet started. At least if it is close to 100,000, it may have started. But if it is very much above, then it won't have started yet. The lower the platelet count, the more likely that the patient is having the plasma leakage. So usually, if it is a count of about 80,000 or so, although it is possible that they are leaking, it's unlikely. But if the count is about 40,000 or 30,000 or 20,000, then there's a good chance the patient is also having a leak. And once the platelet count starts to rise, that means the plasma leakage definitely over, then the patient is on the way to recovery. But of course, there's a lactic period between the discontinuation of the plasma leak and the platelet count rise. So, for example, you might find that in the critical phase, the cytokine response stops around the middle of the critical phase, but the platelet count won't begin to rise until end of the critical phase or beginning of the recovery phase. So there's a lag period of maybe a day or even more than a day before the platelet count rises. But certainly by the time the count has started to rise, you can be sure that the plasma leak has now already finished. Then with regard to bleeding, there are several reasons why they bleed in dengue fever. One is there can be an immune-mediated low-grade DIC, which can produce mucocutaneous bleeding, such as gum bleeding. They will also have a slightly abnormal coagulation profile, such as prolonged prothrombin time and prolonged APTT. But this is a very mild bleed. I mean, usually we don't find severe DIC-like picture in dengue fever. The second reason can be due to thrombocytopenia and an organ problem. Like, for example, let us say that a patient has a peptic ulcer. When the platelet count is normal, the peptic ulcer won't be bleeding because there are enough platelets. But when the platelet count drops to a lower level, then the ulcer can start to bleed, giving rise to upper GI bleeding and melena and so on. Similarly, if the patient has fibroids, when the platelet count is normal, there won't be any bleeding per PV except during menses. But if the platelet count drops, they can start having heavy PV bleeding even between the periods. The other dangerous thing is if they have a AV malformation in the cerebral circulation, when the platelet count is normal, there won't be a problem. Those AV malformations won't give rise to bleeding. However, when the platelet count drops to low levels, if there happen to be a AV malformation, they can get a subarachnoid hemorrhage, and that's a situation where the patient is almost always can't be saved. Similarly, if there's let's say, for example, if there's an eye pathology of some kind, like AV malformation in the eye, for example, during a situation when the patient's platelet count is normal in health, the eye will be fine. But when the count drops, they can start having intraocular bleeding. And the problem with intraocular bleeding, of course, is, as you know, it's not a life-threatening bleed, but unfortunately, it can threaten the vision. Well, there are possibly other mechanisms also, maybe even combined mechanisms, giving rise to what is called occult bleeding, where you don't see that the patient is bleeding. There is no mucocutaneous bleeding, there is no skin bleeding, there is no melena, and yet they seem to be bleeding inside from all the parameters. And that's a very dangerous situation. And sometimes that's one reason why they die. And when autopsies are done, they have found that there is extensive internal bleeding, intraperitoneal, intramuscular, inside the intestinal lumen, and so on. And it's difficult to understand why that has happened. Is it because of a high-grade DIC or what? But for some other reasons also, there may be bleeding. And that is one of the frightening things about dengue hemorrhagic fever, because it's occult bleeding, and therefore we can't see from outside. We have to very carefully monitor the patient clinically and with regard to the packed cell volume in order to determine if that is happening. Now, they can also get organ failures. The most likely organ failure is acute liver failure. They get a type A hepatic encephalopathy. That basically means the liver is previously normal. It can happen due to three reasons. It can happen due to the virus, basically a virus-induced hepatitis or viral hepatitis. That's not very common, but can happen. I mean, it's not rare, but not very common. The more common reason we see is if the patient goes into shock, they can get ischemic liver injury and give rise to hepatic encephalopathy. Now, this is more common or more severe in patients with NASH or obesity. NASH is, as you know, non-alcoholic steatohepatitis or obesity. People don't know the exact reason why, but it's believed that, the liver gets two blood supplies, the hepatic arterial supply and the portal venous supply. The liver depends on both to maintain its oxygen supply. In NASH and obesity, in fatty liver conditions, the blood supply is already compromised due to the fatty liver nature in the liver. And in that situation, if there's a shock, especially, as you know, one thing that happens during shock is that there is severe splanchnic vasoconstriction, giving rise to, in order to maintain the arterial blood volume and pumping of blood to the heart and the brain. So in that situation, the portal venous blood flow drops to very low levels, almost zero. When that happens, the liver becomes completely and quickly hypoxic, and that gives rise to ischemic liver injury. So patients with NASH and obesity, their blood flow is already a bit compromised because of the fatty liver. So that's believed to be the reason why they are more prone to develop ischemic liver injury. What I'm trying to say is sometimes they can develop ischemic liver injury even without much shock. I mean, if you have severe shock, of course, anybody can get this. But the part thing about NASH and obesity is that dengue patients who develop sometimes very subtle shock or sometimes a little amount of prolonged shock can end up with ischemic hepatitis. Then the third reason for acute liver failure is drug-induced. For example, the use of NSAIDs for fever can give rise to Reye syndrome, just like in the case of influenza. So that's a very important point to remember, because it basically means you must never give NSAIDs for dengue patients during the febrile phase or critical phase or any phase. That's a very important thing for all of us to remember wherever we are working. When the patient gets fever, we can always give paracetamol. That's not a problem because it doesn't produce Reye syndrome. But as I'm sure you know that when you get dengue fever, the fever is very high in the febrile phase. And when you give paracetamol, the fever does not come down very easily. Even if it comes down, it does not stay low for 6 hours. So, it rises again in about 3 to 4 hours. So, like the fever is either always high or it quickly comes back to high levels after paracetamol. So you are supposed to take paracetamol every 6 hours. So patients what they do is they become very worried. They take it every 6 hours and they find the fever doesn't come down, or they find the fever rises again very quickly. And, like in that situation, they have the idea, the misconception that this high fever is dangerous. Therefore, they take paracetamol again. So they might take it every 4 hours, giving rise to paracetamol toxicity to the liver. The other thing that they might do is they might get another antipyretic such as ibuprofen or meloxicam or naproxen or mefenamic acid or something like that, believing that in order to avoid taking paracetamol too often, they do go for a second one. I mean, even general practitioners and pharmacists also dispense NSAIDs, not realizing that this is bad. One of the commonly prescribed medicine is mefenamic acid, because mefenamic acid is actually an NSAID or NSAID, but it was originally marketed as a medication for dysmenorrhea. So some GPs actually don't know that it is an NSAID. They think it's a dysmenorrhea medication. So when doctors are advised to give only paracetamol and not to give NSAID, after giving paracetamol, if the fever is still high, they give mefenamic acid, thinking it is not an NSAID. They think it's maybe the same thing like tramadol or codeine or something like that. But that is wrong. Mefenamic acid is actually NSAID, and very frequently they give rise to Reye syndrome and also bleeding. And people who get NSAIDs in the febrile phase are probably more likely to develop more bleeding during the critical phase. Bleeding problems and problematic blood bleeding requiring transfusions are commoner when they have been getting NSAIDs. So remember not to give any NSAIDs, and remember that mefenamic acid is also an NSAID. Only give paracetamol and don't give it more frequently than 6 hours. So then what do you do about this fever? The fever is not going away. It's not a problem. It's not a danger to the patient. So reassure the patients not to worry about the fever. Of course, you can try keep it sponging and so on, but let the fever be there. It's not a problem. It doesn't kill the patient. The second organ failure is acute kidney injury, which usually happens secondary to shock, giving rise to acute tubular necrosis. In other words, dengue does not produce direct kidney injury, but rather if it produces shock, hypovolemic shock, that can give rise to acute tubular necrosis. The third organ failure that is important is acute cardiac failure, which is due to myocarditis, and this can occur not only during the febrile and critical phases, but also during the convalescent phase. Sometimes it can happen even about 2 weeks after recovery from dengue also. So, which is one reason why we tell our patients to rest at home for about a couple of weeks after recovering from dengue, because if you exert yourself while you're having myocarditis, there's more likelihood that you will become symptomatic and go into heart failure. Rarely, dengue can also cause encephalitis, including a cerebellar syndrome, as well as pancreatitis. Okay, so if you look at the natural history, when you get dengue infection, most infections are asymptomatic. And among the symptomatic ones, most symptomatic patients have only mild disease. They simply have a differentiated acute febrile illness. The others can have one of 3 syndromes. That is dengue fever syndrome, dengue hemorrhagic fever stroke dengue shock syndrome or DHF-DSS, and expanded dengue syndrome. Dengue fever syndrome is basically diagnosed on the basis of clinical features without any leakage features, and some, of course, if possibly confirmed by a NS1 antigen. Basically, the management of dengue fever syndrome is anticipatory management, which is basically means you are watching out for the development of shock and organ failure. DHF-DSS is when there is a leakage, and here the important management point is to manage the shock or management for the prevention of shock. The third syndrome is expanded dengue syndrome, which is basically dengue with a liver with a organ failure, such as liver failure or kidney failure, when that organ support also becomes very important. And as you can understand, sometimes number 2 and number 3 can happen together. So let's get on to clinical management. As you know, there are 3 phases: the febrile phase, the critical phase, the recovery phase. But the critical phase does not happen in all the patients, only in those that develop what's called dengue hemorrhagic fever. That is the patient who develop leakage. So basically that happens only if there's a antibody-dependent enhancement and higher viremia. So this is a graph that shows what happens during this febrile phase and critical phase and recovery phase. You can see there are 3 columns. This is the first column, the febrile phase, the white part. The second column is the pink one, which is the critical phase. The third column is the recovery phase. So in the febrile phase, as they first come, they have high fever. They have the normal hematocrit. This is the hematocrit, the normal hematocrit, and the platelet count, which is originally normal but starts to fall. And they have a viremia also. Now, the viremia, this graph about the viremia is actually rather wrong. You know that the viremia is highest on day 1. Well, actually, it's not wrong. It's right, actually, because day 1 is here, no? Yeah, it's right. Yeah. So the peak is on day 1. So it rises to a peak during the incubation period when the patient is asymptomatic. When they start having the fever, the viremia is highest, and then it gradually falls. Now, this point is very important because it is the viremia that gives rise to NS1 antigen positivity, because NS1 antigen is a component of the virus. Now, therefore, the best time to do the NS1 antigen is day 1, when the viremia is highest. That's the time when you are most likely to get a proper positive result on NS1 antigen test. Now, unfortunately, there is a very sad belief among doctors that the best time to do the NS1 antigen test is day 2 or day 3. That is wrong. The best day is day 1. By day 2, the viremia is less. Therefore, you might get a false negative. Day 3, the viremia is even less. Therefore, you might very well get a false negative. After day 3, there's no point doing it because usually it is negative. So as soon as they come with fever, don't wait for day 2, do a viremia, do a NS1 antigen. Normally, of course, on day 1, when they have high fever, we don't know for sure whether it is dengue, so we also do a full blood count and a C-reactive protein along with the NS1 antigen. So those are also useful because the C-reactive protein would not be very high. The normal is up to about 6 or so. You might have a CRP of about 10 or 20, so that will be compatible with dengue. But if you find the CRP is about 50 or 60 or something, it is very likely that what you are seeing is actually a bacterial infection. Similarly, full blood count on day 1 is also very useful because you can get an idea about the baseline hemoglobin, baseline paxil volume, and the baseline platelet count. And normally you also have a leukopenia on day 1, while the PCV and hemoglobin, PCV and platelet count are on day 1 probably still normal. You might find a platelet count of about 300,000 or so. So as you watch during the febrile phase, gradually the temperature comes down and the platelet count also starts to fall and the hematocrit starts to rise and the NS1 becomes negative. And if there's a problem in the febrile phase, that's usually because of fever and vomiting giving rise to dehydration. Sometimes the dehydration may be so prominent that it might also cause hematocrit rise by about 2 points. So it might rise from 38 to 40 or something like that, or 40 to 42. Then you get the critical phase, the pink part. When that happens, the temperature suddenly falls to normal or even subnormal. And the hematocrit rises with the plasma leakage. Platelet count is very low. Now, antibodies are starting to form, but still the antibody tests are not yet positive. It's still not sensitive enough. And this is the time that you get shock and bleeding, sometimes also organ impairment. About 48 hours later, this period finishes and the patient starts to recover. And again, the platelet count rises, right? And platelet count, this is the platelet count, I'm sorry, this is the platelet count rises, and the hematocrit becomes, which was high again, comes back to normal. And the fluid that was leaked out, that had leaked out during the febrile, the critical phase, will become reabsorbed back into the vascular circulation. And after about 5 days, the antibodies are positive. So after 5 days, if you want to make a diagnosis, you can do the IgM antibodies. So let's take phase by phase. Let's start with the febrile phase. It's a very acute onset high-grade fever lasting 2 to 7 days. Other clinical features are there's facial flushing, meaning the face looks very red and flushed. There's conjunctival injection, so you have red eyes. Diffuse erythema in the skin, which is blanching. There can be headache, arthralgia, myalgia, and body aches. Sometimes there may be some mild bleeding, especially mucosal bleeding. There can be tender hepatomegaly, and some patients, they also have a sore throat and injected pharynx. So you might get the feeling that it's a viral upper respiratory infection. So be careful. The presence of a sore throat or the presence of a cough does not mean that they are not having dengue. They can still be having dengue even though they have a sore throat and a cough. Various other symptoms have been seen in certain epidemics. For example, there was one epidemic where diarrhea was very common. So be careful. Just because there's diarrhea, don't think it is not dengue. It could still be dengue. If you do a full blood count, you will find that the leukopenia is almost always there. And the dengue NS1 antigen is positive for the first 3 days or so, and thereafter it is unreliable or useless to do. And as I said earlier, the IgM antibodies start appearing after day 5. So there's no point doing antibodies before day 5. Now there's a period between day 3 and day 5 when both the antigen test is negative and the antibody test is also negative. So during that period, you can't make a confirmation. So do these patients need hospitalization in the febrile phase? Patients in the febrile phase need to be admitted for only rare reasons, such as if they have comorbidity like heart failure or something, or if they are pregnant, or if there are social reasons that there is no one to look after them, or they can't travel to hospital quickly, and so on. So you must take a very careful history to check whether they have any comorbidities, whether they have any, whether they are pregnant, and you must take a social history to see if they can be helped, if they can be looked after at home, if they can rest at home, and so on. Otherwise, if they are staying at home, you must give instructions about various things. You must tell them to take enough fluids to maintain hydration. Some people believe that they must limit their fluid intake. Yes, of course, but not in the febrile phase. That's in the critical phase that you must limit the fluid intake. So in the febrile phase, you can drink as much fluid as possible as you need, and there's no need to be dehydrated or to stay thirsty. You can drink whatever the amount that you want. Of the fluids that you drink, about half should be water, and the other half should be something other than water, like maybe fruit juices or Tambili or ORS or something like that. Generally, we tell them not to drink red-colored fluids such as some cordials and things, because if they vomit red color, we don't know whether it is blood or the fluid. And also, we tell them not to take citrus fruits or not to take carbonated waters because they can cause gastritis or dyspepsia. Second advice you must give is about food intake. You must tell them to take enough calories and not to worry about taking heavy meals. So what they can do is they can take something like biscuits or buns or something like that very frequently. Maybe every 2-3 hours they can have maybe some biscuits, maybe some bananas, maybe some buns or some bread or whatever. There's no need to eat rice and so on, because if you eat rice like in a normal meal, generally they will vomit. and then they get dehydrated also. So it's better to eat only small meals, which is rich in calories, and take it frequently. The third thing is to advise them to take bed rest, not to exert themselves. And tell them about antipyretics. You can take Panadol or paracetamol, 1 gram 6 hourly. Don't take it more frequently than 6 hourly, and don't take any other antibiotics. You can also prescribe antiemetics if they're having fever, such as metoclopramide, or you can even give them a prescription to be taken if needed. If they are on long-term medications, we need to give advice about long-term medications. They may be on, for example, antihypertensives, anti-diabetes medications, anti-platelet medications, and so on. So those decisions are very important. Antihypertensives generally can be stopped, or you can continue until the critical phase. But after about 2 days or so, it's okay to stop them because by that time they start developing the leakage sometimes. Anti-diabetic medications you may have to reduce because of the reduced intake. Antiplatelets are usually stopped because platelet count anyway drops. Sometimes they are even on even more difficult medications like anticoagulants. Then of course you have to get specialist advice. If they are on medications like anti-epileptics, that must be continued. Medications like anti-asthmatic medications also must be continued. Anti-diabetes medications should be continued, but be careful about the development of hypoglycemia if they don't eat enough. Then the next question is when to come for review. Basically, it's a good idea to check the platelet count every day, or after about day 3, better to check twice a day. And also you must explain what to look out for. Basically, you must look out for the features of hypovolemia, such as postural hypotension, faintishness, and so on, and features of bleeding, such as hematemesis, melena, and so on. So, in the febrile phase, can you predict who will go into severe dengue or who will go into hemorrhagic fever? Now, that's a very important question because, as I told you earlier, we have to monitor them very carefully. And if you can predict who is going with dengue hemorrhagic fever, it will be great because you can limit the number of admissions and therefore limit the burden on the healthcare staff and the hospitals. So because of this reason, various people have done various kinds of research to find out whether there are reliable indicators for predicting hemorrhagic fever. They have tried various clinical features like symptoms and physical signs. They have also tried out various investigations like antibody levels and neutrophil levels and this and that. Now, the unfortunate thing is, after trying all those things, none of these things could be proven as reliably, adequately reliable to predict who gets hemorrhagic fever. So none of the parameters were able to meet the criteria required as a good predictor. However, there are 7 things which are listed here, which almost reached statistical significance. They did not reach significant levels, but they almost got there. So because of that, we can't call them predictive signs because they did not predict with statistical significance, but we call them warning signs. These are abdominal pain and tenderness, persistent vomiting, clinical fluid accumulation like pleural effusions, mucosal bleed, lethargy and restlessness, liver enlargement more than 2 centimeters, and if you can do laboratory investigations, an increased hematocrit concurrent with a rapid decrease in platelet count. That happens very close to number 3 and number 7 happen very close to the critical phase. So these are called warning signs. If those warning signs are present, it's a good idea to admit the patient without waiting for the platelet count or anything to drop. But remember, you can still get hemorrhagic fever without warning signs also. And that's what this diagram shows. You can see that the left circle is dengue fever. The inner circle in the left circle is with warning signs. Outer part is without warning signs. Now, both of them have arrows going into plasma leakage or severe hemorrhage and so on. So if there are warning signs, we admit the patient always. But even without warning signs, it doesn't mean that they can't get hemorrhagic fever. So remember that. I mean, they still have to be monitored very carefully. Because as I said earlier, even these 7 parameters did not reach statistically significant levels to be reliable predictors. Then let's come to the critical phase, which only some patients develop. That usually occurs on day 3 to day 7. It doesn't happen in the first 2 days and doesn't happen after day 7. So day 1, day 2, you are safe. Day 8, 9, 10, also you are safe. The ones where you have to look out for are day 3, 4, 5, 6, 7. And it lasts 24 to 48 hours. Now, how it registers the presence is, there's a sudden effervescence, that is, sudden disappearance of the fever. Temperature initially comes down to 37.5 to 38, and then it becomes normal and might even become subnormal if there's shock. So this is the time when they can have possible complications like plasma leakage, bleeding, or organ impairment. So how do we identify the beginning of the critical phase? That's a very important point. Some clinical features are sudden effervescence, feeling or looking ill, features of plasma leakage such as the pleural effusion, features of shock such as reduced blood pressure or pulse pressure and increased capillary refill time or reduced urine output. On the ultrasound scan, you might find fluid around gallbladder or right side pleural effusion or fluid in the Morrison's pouch. In the blood test, you will find the platelet count is less than 100 and the PCV is starting to rise. That's when you realize the patient has started having the critical phase. And we need to try to time the beginning of the critical phase, which is always a bit difficult. Normally, the most reliable way to time it is to look at the ultrasound scan, and we take that if there's a gallbladder fluid down the gallbladder, we say about maybe 4 to 6 hours, and the effusion also we take about 6 hours beforehand. So that means if we do the scan at about 8 o'clock in the morning and there's pleural effusion, we will say that the leakage started at 6 o'clock. 6 hours before 8 o'clock, which is like 2 a.m. So we start counting from 2 a.m. for the 48 hours. So how do you manage the critical phase? Remember that it lasts only 24 to 48 hours. It has a spontaneous reversal, but if it is prolonged, can lead to organ failures like liver failure. IV fluids are given in this stage, but they can lead to volume overload in the next stage. And therefore, we give minimum amount of fluid necessary to maintain tissue perfusion and urine output. But of course, what do you mean by this necessary amount is fairly controversial. There are two groups of people, two groups of clinicians. Some believe that you should be maintaining something like output of about 0.5 ml of urine per kilogram per hour. Some people believe you should be maintaining twice that amount, like 1 ml per kilogram per hour. So there are two camps really. Especially during pregnancy, we don't like the 0.5 level. We normally go for at least 0.75, if not 1 ml. And the other important point of the critical phase management is to watch out for bleeding. So how do you monitor? You check the peripheral perfusion, for example, the color and warmth of the peripheries, capillary refill time, and the urine output. Then we check vital signs such as blood pressure and pulse rate, and the hematocrit. And of course, we use the monitoring charts, which are available with the 2012 national guidelines. Giving IV fluids, we calculate according to the body weight. And although the guidelines advise us to use the ideal body weight, which is based on the height, most clinicians actually use the actual body weight. And if it is more than 50 kilograms, we stop at 50 kilogram level. And again, some clinicians actually take the real body weight also, although the guideline says if it is more than 50 kilograms, not to consider the extra amount, to limit the fluid amount to 50 kilograms. Now, there are two types of fluids. There's maintenance fluid and correction of maintenance fluids and correction of hypovolemia. Now, maintenance volume is calculated according to the body weight up to 50 kilograms and is given over 48 hours, but not evenly. You give a little at the beginning, more in the middle, and little in the end. So it's a pyramid-shaped one because the leakage starts with the critical phase and becomes increased towards the middle, that's to 24 hours, and then starts to reduce. So it's like it has a pyramidal shaped. So there's an ascending limb and a descending limb. So during the ascending limb, we give more fluids, and in the descending limb, we reduce the fluid amount. Other complications that can happen are either hyperglycemia or hypoglycemia. Hyperglycemia is very important because it can cause polyuria, and that can make you feel that the output is good, but actually it's because of polyuria due to hyperglycemia. So we'll be very careful. Hypo, of course, is also important. You must correct that. There can be electrolyte imbalances, especially sodium, potassium, and calcium, as well as acid-base imbalances. And some people routinely give IV calcium also. And of course, there can be organ failures. I mentioned liver failure, kidney failure, and myocarditis. And watch for unusual bleeding, and watch for nosocomial infections, especially with cannulas and catheters. The recovery phase usually lasts for about 48 to 72 hours, during which time there's progressive clinical improvement. The patient has improved general well-being and hemodynamic stability with diuresis and bradycardia. They might also get a rash, what's called the convalescent rash, which is like a coppery red rash over the palms and soles, as well as the trunk, which is very itching. And the blood tests, which were abnormal earlier, come back to normal. And the leaked fluid from the pleural space and all that is now reabsorbed back into the circulation. And if we have been giving too much fluid during the critical phase, the reabsorption can give rise to central volume overload also. So in the recovery phase, the management is basically to watch for volume overload. But sometimes unusual hemorrhage that began covertly in the critical phase can continue and become overt in the recovery phase. So be very careful. Their bleeding doesn't stop with the critical phase. Now talking about shock, you must remember the blood pressure changes, the sequential changes in the systolic and diastolic blood pressures. As you remember, first of all, what happens is the diastolic pressure rises and the pulse pressure narrows. The second thing that happens is that the systolic pressure falls. So the systolic pressure alone can be misleading. You must check the systolic and the diastolic and check the pulse pressure also. And usually we like to keep the pulse pressure at least 25. There are two types of shock. One is called compensated shock. The other one is called hypotensive shock. In compensated shock, there's poor peripheral perfusion, but the systolic pressure is maintained. We can see that very easily. If we ask the patient to stand up, they get postural hypotension and postural tachycardia. On the other hand, in hypotensive shock, they have even hypotension in the lying down position with a systolic of less than 90 and a mean pressure of less than 70. The reasons for the shock can be because of a leak or a bleed or even a leak plus bleed. Rarely they can have a shock because of myocarditis or sepsis. So giving IV fluids, we normally start with IV crystalloids. It's given in the guidelines, the rates, how to start and how to reduce and so on. We can, if the IV fluids don't work, sometimes we give colloids also. All this is given in the national guidelines. You can read that for yourself. That's reliable. But remember that if shock is persisting after giving fluids, we can give repeat boluses only as long as the hematocrit remains high. So each time that we decide about giving more fluids, you must recheck the hematocrit. That's very important. And you should be giving crystalloids or colloids only if the HCT is high. If the HCT is falling, we must consider bleeding. If the HCT is not as high as expected for the degree of shock, it can be leak plus bleed. So again, in both situations, you need blood transfusions. If the response is not there after giving about 40 to 60 ml per kilogram of fluid, again, we have to consider bleeding. Giving blood, we can give either fresh pancreas cells or fresh whole blood, more useful than giving stored blood, although sometimes we have to give stored blood also. These are the volumes, again, given in the guidelines. And the rate is determined according to the clinical status, because as you know, anyway, it has to be given within 4 hours of taking the blood pack out of the fridge. But sometimes we have to give it very quickly, depending on the clinical status, provided the patient does not have comorbidities such as heart failure. Platelet concentrates, FFP, and cryoprecipitate are given only if there is no response to blood transfusions. Otherwise, they are not given routinely. Fluid overload is more likely if IV fluids continue to is needed to give given. It has to be given beyond the critical phase. If you use the wrong fluid volume or rate or type, or if patients are given FFP, platelet concentrate, or cryoprecipitate because they are very rich in sodium, or if they are having comorbidities or myocarditis. Right. Before I start some cases, do you want to ask any questions?
So antibody levels, sir, when do we do it? So clinically, is there usually do we do it in practical setting?
Yeah, I mean, it is nowadays hardly ever done, to be honest. We used to do it when before the antigen test became available. But even then, when we did the antibody, by that time, the diagnosis was already evident. So you are right, there's hardly any need to do antibodies anymore, maybe for research purposes, but not for clinical management.
Thank you, sir.
Okay, I just present some numbers and let's try to make a diagnosis. So case 1. So what's the diagnosis? Why is the hemoglobin dropping? You can type your answers to the chat box. Any other answers? Only 4 answers. Do you think that the patient is in the critical phase? Do you think that they are having critical phase? This patient is having critical phase. So it is day 4 of fever, and the platelet count is 80. Well, if you did an ultrasound scan of the abdomen, do you think you will find a lot of fluid leakage? Do you think that the patient will have bilateral effusions and so on? With a platelet count of 80? The platelet count has only just fallen below 100,000. So, at the most, the critical phase is only starting now. So, by already, can the patient have leakage? So much that the blood pressure has dropped to 80. The patient is definitely in shock, because the systolic pressure is less than 90 and the pulse rate is 100. and the refill time is more than 3 seconds. So the patient is in shock, hypovolemic shock. But the question is, why is the patient in hypovolemic shock? Is it because of hemorrhage, or is it because of leakage, or is it because of both hemorrhage and leakage? And there's evidence of hemorrhage because she has metrorrhagia. Does she have evidence of leakage? And would you expect this patient to be having significant leakage at this stage of the illness when the platelet count is 80,000? What do you think?
Pain seems bleeding, sir. PCV is also 30, it's decreasing.
Sorry, I can't hear. I can't hear you. Sorry. Can you repeat that, please?
It mainly seems to be bleeding, and the aspect of leaking is very less because hemoglobin also falling and PCV is also falling 32 along. But as you said, platelets is just started falling below 100. It's yeah.
Yes, so that's right. So you can be very clear that there is shock, no? And you can also be very clear that this is a hemorrhagic shock because the PCV has fallen. So that part is absolutely certain. But the question is, it's unlikely that the patient is in so much of shock because of a drop in, because of a plasma leakage, because the platelet count is still only 80,000. You know, it would have started, it began with 200,000 on day 1, then into day 2 and day 3, and now day 4. On day 4, it is just below 100,000. So it's very unlikely. This is the sort of patient that I would expect, and she can go into leakage later on, but at the moment, I would say she either does not have leakage or would be having only a small amount of leakage. That can't give rise to this sort of hypotensive shock with a systolic pressure of 80, heart rate of 100, and a refill time of more than 3 seconds. So the shock and the drop in hemoglobin must be because of hemorrhagic shock. So the reason for her changes, the reason for her shock and the blood investigation changes is probably the metrorrhagia. So if you want to correct her shock, I mean, obviously you must correct her shock. There's no doubt about that, because with a mean pressure of, with a systolic of 80 and a pulse rate of 100, she's in trouble. But in order to correct her shock, what you have to give is blood rather than plasma, because rather than saline, because the problem is not leakage, but hemorrhagic shock. Hemorrhagic shock not because of dengue hemorrhagic fever, but because of an unusual bleeding, maybe from a uterine fibroid or something like that. She's not in DHF because she probably hasn't gone far enough in the critical phase. She may be only just entering critical phase. So this bleeding and this shock is not because of critical phase. It's because of the metrorrhagia. So this is what you call unusual hemorrhage. You know, like dengue fever with a low platelet count can produce bleeding from an abnormal organ, such as the womb or the uterus with a fibroid. Do you understand that? Do you want any clarifications on that?
So then, isn't this bleeding is attributable to the dengue?
Due to the thrombocytopenia. You know, a woman with a fibroid, for example, would be able to maintain a reasonable menorrhagia during periods with a normal platelet count. But the moment the platelet count drops to about 150 or 100 or something like that, the same fibroid will start bleeding heavily, not during periods, but even in between, but immediately, you know, even if it is away from the, between the, in the middle of the cycle. So you can, I mean, yes, it is due to dengue in the sense that the dengue causes the thrombocytopenia and therefore produce the bleed. It's not because of a DIC or not because of any dengue antibody mediated or immune mediated bleed. Any other questions? Any other clarification that you want?
So since it's we are quite sure that there is dengue and there is hemorrhage is also there, and which is attributable as a pathogenesis, as a is it due to thrombocytopenia which is happening in the dengue? So then why can't we call it dengue hemorrhagic fever?
Because dengue hemorrhagic fever as a term is used for the problem that happens during the critical phase, during the leakage. dengue hemorrhagic fever as a name means dengue and hemorrhage. That is right, but that's not the meaning of the term. The term is a specific technical term. Dengue hemorrhagic fever, DHF, is something that happens in the critical phase due to the cytokine storm, the plasma leakage, and all those things. In fact, some people say it should be called dengue leakage fever, not dengue hemorrhagic fever. Of course, if they do bleed in the hemorrhagic fever, if they go as far as to die and when you do a post-mortem, you find that there's internal bleeding, and therefore it's okay to call it dengue hemorrhagic fever. But the term DHF is limited to that situation in the critical phase when they are having those problems, not simply for a patient who is bleeding with dengue. Any other
so it's that leaking what matters.
Yes, that's right. Yeah, leaking is what matters for the term. Any other clarifications? Okay, let's get on to another case. What about this one? So type in your answers to the chat box. Any other answers? There's only one answer so far. Can I just know in which year are you now? What is your year? Year 1, year 2, year 3, year 4, year 5? Someone? Anyone answer? Let's say I'll ask someone. Udana Jayatilaka, which year are you?
Yeah, final years.
Final year. So that means you have done your medicine appointments. You know, like the third year, fourth year appointments?
Yes, sir. And one prof appointment I've done so far.
I see. You want the proper. Oh, I see. Any other answers? So Hansen and Priyan, you said dehydration. Tell me why you think it's dehydration, Hansen?
Still the patient is having fever. It's the fever day 3. And also usually to say the PCV should rise by 20% from the baseline to go into the critical phase. And the hemoglobin is also concentrated. So I thought it is dehydration rather than the going into the critical phase.
Well, you know, one little correction I want to make, Hansen, is this 20% above baseline. There is a definition like that. You are right about that. So, for example, now in this patient's case, the baseline PCV is 40 now. So 20% of that is 8. So it is when 48 is, when it has gone from 40% to 48%, we say it's a 20% rise. That is, of course, correct. That definition is there. However, for all practical purposes, let us forget about this 20% thing, because we don't wait until that to make a diagnosis. We try to make a diagnosis much earlier than that. Maybe with the rise of the PCV by about 4 points or 5 points or something, maybe even earlier if possible. So, I mean, still we do see 20% rises. I won't say no, but normally we start giving IV fluids much before that. And therefore, we don't allow it to rise by 20% above baseline. And therefore, clinically speaking, we rarely see that sort of rise anymore because we correct it before it happens. Definitions, of course, are there, but, you know, I mean, occasionally you might see a 20% rise. In that case, you can go by the definition and say it is leakage is there and all that sort of thing, but it's normally not very useful anymore. So that's one point that I wanted to raise. The other thing is, in her case, her platelet count is still 95. So it is just below 100. Now remember, just before, you have to get this very clearly into your mind. I told you that their critical phase starts only after the platelet count drops below 100,000. That is correct. But I did not tell you that people whose platelet count is less than 100,000 are in the critical phase. There's a difference between those two. If they are in the critical phase, their count is always less than 100. That is correct. But if their count is less than 100, they are not always in critical phase. Other way is not right. Sometimes the count is less than 100, but they are not leaking. If the count is more than 100, more than 100, you know for sure they can't be leaking, because I told you earlier that the leaking starts only after the count is less than 100. But that doesn't mean that everybody with a count of less than 100 is now leaking. Sometimes it can be 90, 95, 80, 70 and not leaking. If the count is very low, then you are sure that they are leaking, maybe 40, 30. Certainly if it is 20, then it would be certainly leaking. So don't get it the other way. What I said is, those who are leaking have a count of less than 100. I did not say that those who are having a count of less than 100 are leaking. Do you understand that? Did you get that? Hansana, did you understand that?
Yes, sir.
Okay. Now, in addition to that point, I have also said that there are no effusions. Okay. So that means, like even ultrasonically, there is no evidence of leakage. And also, she is not in shock. The PP is 100, heart rate is 80, refill time is less than 3 seconds. So she still has a fairly good intravascular volume. No evidence of shock also is there. If that is the case, why has the patient's hemoglobin gone up from 13 to 15? Or why has the PCV gone up from 40 to 44? What is the reason for that? What do you think is the reason for that? Anyone? Can you type your answers? Yes, hemoconcentration, but why hemoconcentration? What is the reason for that? If it is not leakage, why? So this is a situation where you must take a careful history from the patient and ask and check whether she may be dehydrated, giving rise to hemoconcentration and the rise of plexal volume in the absence of leakage. So we can ask the patient, in the last 3 days, how much of fluids were you taking? Did you have vomiting? Did you have diarrhea? Was your fever very high? Because as you know, when there's high fever, they sweat a lot and they lose more fluids. So by talking to the patient, you can get an idea. So I would say that probably this patient would have said, I did not drink enough fluids. I feel very thirsty. I had very high fever and I vomited several times, maybe 7, 8 times. All this would indicate that there's, reduced intake, increased loss, therefore dehydration. And that dehydration would have produced the hemoconcentration, PCV2 rise. It's a very significant rise from 40 to 44. Normally, the rise due to due to dehydration is not so high, maybe from 40 to 42. But anyway, we know for sure there's no leakage in this particular patient because the platelet count is only now dropping below 100. And anyway, we know there are no effusions. So this is basically what happens in the febrile phase. They can have severe vomiting. They have reduced so Sasindra has said it can be due to starting of leaking or dehydration in febrile phase. So I hope you can, Sasindra, I hope you can now differentiate between those two possibilities, whether it's due to starting of leakage or dehydration. Anyway, starting of leakage can't produce a PCV of rise of 40 to 44. No? So, I hope now you can now differentiate between those two possibilities. Any questions, any clarifications you want?
So with you said, sir, like the dehydration has to be very severe in order to give such a rise in the PCV. But still, is it possible to have a capillary refilling time less than 3 or 2 seconds with that much of a dehydration?
Yeah, maybe you might have even a low blood pressure due to severe dehydration. But, I would imagine that the PCV is probably rising from 40 to 44 is pretty high. And hypotension can also happen. CRT increase can also happen, but they are much less likely to happen, unlike in the case of leakage. Because the dehydration is not, the reduction in the plasma volume is not that significant. That is why I say that the PCV rise from 40 to 44 is pretty significant. There are other reasons why the PCV rises also. For example, people during the stress of acute fever sometimes has a stress-induced PCV rise also. That's also fairly commonly seen in dengue fever, and that also comes back to normal when the patient recovers. So, these are, of course, real numbers which I have given. So it's a little unusual in that sense, where the PCV would have been more like 42. But, because that combined with a little bit of stress-induced polycythemia or stress-induced erythrocytosis may have been there. That is, I think, the likely explanation. But anyway, certainly I would say leakage is not on the cards. Okay, did you get that?
Yes, sir.
So this sort of patient, to correct this plexal volume correction, what would you give? You would give oral fluids and IV fluids. You won't give blood. No, you won't give even IV fluids is not very necessary. You can give IV fluid, that's okay, because if you want to correct it very quickly before the critical phase starts, you might give it. But if the patient is far away from the critical phase, I might have even just used oral fluids. But of course, you must remember that this patient is probably vomiting also, so giving oral fluids can be a bit more problematic. But IV is fine, but even oral is fine if it is feasible. Any clarifications? Do you want any clarifications?
Sir,
Yes.
so without effusions, can we even like without effusions, can we exclude leaking? Because like for clinically detectable fluid, have to be there to have an effusion like?
No. The effusions, you mean to say clinical effusion, right?
Yeah.
Yes, of course. Clinical effusions will happen only a little while later, but we do the ultrasound scan and we look for fluid around the gallbladder and the in the pleural space. Those effusions are very sensitive. Clinical effusions, of course, you are right. It normally happens. You will be able to detect the effusion not at 6 hours after critical phase, maybe 12 hours after critical phase, maybe 6 hours sometimes, but more than 6 hours. So clinical effusions are detected somewhat later, while ultrasonic effusions can be picked up earlier. Okay. In any event, in this particular patient, with the platelet count of 95, you would not expect leakage because it was 100, it's almost 100. Even if you do a scan of the abdomen, you might, at the most, you will find some fluid around the gallbladder, but you probably won't even find an effusion in the pleural space. So that sort of leakage would be very minimal, and that won't be able to account for this PCV rise. Any other clarifications?
So initially, sir, so when you said that how to anticipate severe dengue, so you said 3 and 7 happen very close to critical phase, sir. And in that, the 3 was clinical fluid accumulation, is it, sir? So in that sense, isn't the clinical fluid accumulation occurring already in the critical phase?
Yeah. You are quite right. I mean, although they are called warning signs, the fact of the matter is you are talking about warning signs in the febrile phase, which is actually rather late. That was a different setting. Now you are having a patient in the outpatient setting in the febrile phase, and you are looking for reasons for admitting the patient. So that 3 and 7, all those things would actually mean that the patient is already in the critical phase. So you better admit then. You can actually clinically diagnose the critical phase already, and then you can admit the patient. So that's a different setting. That is, those warning signs were the ones that were, those were the parameters that, among other parameters, they were tested to see which patients can be predicted to get into dengue hemorrhagic fever and trouble. And they were the ones that came closest. And you can imagine why they came very close to predicting, because they are already having leakage. Okay?
Yes, sir. Thank you, sir.
Any other clarification? Okay, right. So let's carry on with this patient. Now,
Sir, in the previous things, like without the first value, day 1 value, if they just give us the day 3 value, can we say that, can we like confidently say like it's only because of dehydration?
I think you can, because 95 is still too early for significant leakage, no? Or significant critical phase to have progressed, no? Isn't it?
Yeah, but like again, how can we so sure and assure that the fever has exactly day 3 in that case?
To find out if it is day 3, we take a history. Okay. We just ask how many days of fever have you had. So that is certain. And of course, they can come on day 3 without a day 1 full blood count because they would not have done the test on day 1. That is quite a possible situation. So on day 3, when you check the full blood count, if it is 95,000, why are you thinking it is a significant prolonged established leakage? What is the reason? In spite of not having whether the first day one is 212 or whatever, but do you expect the first day one to be otherwise? She is in day 3 and her platelet count is 95. Okay, I said it has to fall below 100. So why do you think that at 95 she will have such a significant leakage? Whatever the first day's count may be. What do you think? Well, do you understand, or do you have any more doubts?
No, sir. No. I just wanted to make clarify, like in the febrile phase, will everybody like usually have fever, or like can somebody like have mild sort of fever and then proceed with the severe thing?
No, the fever is very prominent in dengue. You can't miss it. It's very high. I think you have to very clearly get into your mind what I told about the platelet count and the critical phase, the onset of the critical phase. As I said earlier, everybody in the critical phase has a count less than 100. But everybody with a count less than 100 is not in a critical phase. If you go to, this is the reason why actually I asked which year are you, because you should have seen dengue cases in the wards. I don't know whether it's because of COVID-19 or some other reason that you have not seen enough patients in the wards. But if you have seen patients in the wards, you will know that many patients come to the ward and get admitted, and we monitor their count just in case they get a critical phase, and their counts drop to 80,000, 70,000, sometimes 50,000, and they never get a critical phase. And then they recover and they go home. Their counts are, like admission maybe 140, then 110, then 80, 70, 50, and maybe even sometimes 40, and then go up and so on. So just because the count is less than 100 does not mean that they will leak. Everybody with a count of less than 100 are not leaking. But everybody who are leaking will certainly be having a count less than 100. So please understand that your difficulty of gauging the importance of 95,000 here is because of lack of familiarity with cases. 95 is a very comfortable platelet count. It's not I would be extremely surprised if this patient has any leakage at all. Okay. Any other clarifications that you want? Anyone? Any more clarifications?
Yes, sir. Thank you.
Okay. Right. Okay. So one other thing that I want to tell you, because you are having this little difficulty, I'm telling one more thing actually. One thing that you have to be careful is this. Now, let's say the patient is in the ward now. You are looking after the patient. You take a blood sample at 6 o'clock in the morning. And you see the patient during ward round at 9 o'clock in the morning. And then you get the report of the morning one at 11 o'clock in the morning. Report says 95,000 or 100,000 or 120,000. And you're seeing the patient now. Now remember very carefully, what you are seeing is now that the patient that you are seeing now at 11 o'clock in the morning is not the same patient who gave blood at 6 o'clock in the morning. At 6 o'clock, it may have been 95,000 or 100,000 or whatever. And that means at that time, the patient would not have been in leakage. However, now, 6 hours later, the story can be different. It's like a patient with a pneumothorax, and you take a chest X-ray in the morning, and the chest X-ray comes from the X-ray department to the ward about 4 hours later. Now the patient is different. The patient can be about to die, although the chest X-ray is very small pneumothorax, because that was taken 4 hours ago. So I just said that also because in our ward work, we must remember always to do two things. One thing is, whenever we take a blood sample, we must put down the time that the blood sample is taken. And whenever we get the blood report, on the report, we must write the time the sample was taken. And when we are seeing the patient and looking at the parameters, you must check the time also and make your decisions. But this scenario is different, right? This scenario is not about that number of hours being separated. This scenario is a 24-year-old patient with blood reports and the blood taken just now, and the reports already available to you just now. So don't worry about that. I just told you that because it's a very frequent problem that we encounter in the ward, that delay in the report coming. But in this case number 1 and case number 2, don't worry about that. This is like, I'm telling you, there's no fooling here. This count is very fresh. 95 is very fresh. Even with a very fresh count of 95, if there are no effusions and if the features are like this, you can be sure, because the count is 95 and there are no effusions also, there is no leakage. Because I told you, those who are leaking have a count of less than 100, but those who are less than 100 don't always have leakage. They will start leakage after 100. So at 95, they won't be having any significant leakage, even if they happen to be leaking. Many patients who come to ward and drop the count to about 80 or 70 never have leakage. So it doesn't always mean below 100 is leakage. So in such a patient without any leakage, how can the PCV rise from 40 to 44? The most likely explanation is dehydration due to vomiting, reduced intake, high fever, diarrhea, all those things. And as one of you raised the point, can it be so high? Well, yes, you are right. But in this particular patient's case, I suppose it's also possible she also had stress-induced rise in the PCV. That's also a fairly common thing. Okay, is that clear to you? Do you want any? Do you understand that, or do you want any clarifications?
Understand.
Okay, right. So now the same patient. Now this is day 3 now. Now let's say what happens later. So we now rehydrate the patient. We are going to give oral fluids and IV fluids and rehydrate the patient. And now these are the levels. On day 3, it got corrected to 41. Platelet count is 90 after correction. That is day 3 now. Earlier also I said day 3, platelet count is 44 with dehydration. Platelet count has dropped to 95. Then after correction, PCV has gone to 41. Come down to 41, and the platelet is now slightly less, 90,000 on day 3. And now day 4, PCV 46, platelet 40. I have given the features. What is the current status? What is the current status? What is happening now?
Now she's in critical phase. She's leaking.
Right. Do you all understand that? Right. This is a clear-cut critical phase because now she has progressed from 41 to 46 with a very sharp drop in the platelet count. Okay. And she has got effusion. So there's no doubt about the fact that she is in leakage. The effusion is there. The hemoconcentration is there. And naturally, the platelet count has also dropped sharply. In addition to that, you can say she is also in shock because the systolic pressure is 90. Heart rate is more than 105, and the refill time is more than 3 seconds. So she is definitely in hypotensive shock, not even compensatory shock. She is actually in hypotensive shock, and because of leakage. That's why there's so much of hemoconcentration. So day 3, she came with dehydration. We corrected the dehydration. Day 4, she went into leakage and hypovolemia and hypotensive shock. This is a very common situation. If they come on day 3 or just around the time of the beginning of the critical phase with dehydration, we must very quickly correct the dehydration. The reason for that is if we keep her hypovolemic due to dehydration and then they leak, they get in trouble much faster. because they start off the critical phase with a low blood volume, they will become shocked very quickly. So when you see a patient with febrile phase, if you see any dehydration, as quickly as possible, correct it. You might remember I told you earlier that when I was showing you the previous slide, I told you we will correct this patient by giving oral fluids or IV fluids. That you might want to give IV fluids to correct it quickly before the critical phase. That's what I meant. I don't want to waste time correcting the dehydration. I want her to be rehydrated ASAP because I know she could go into shock very quickly. She could go into leakage very quickly. So if you go into leakage, better for you to start from a normal volume rather than from a hypovolemic state. So if they come dehydrated, better give them normal volume as quickly as possible before they develop their leakage. So this is a clear-cut case of leakage because of the effusion, the hemoconcentration, and the drop in the platelet count from 90 to 40. Plus, she actually also has already got hypotensive shock because of the blood pressure being systolic being 90, heart rate being 105, and the refill time being more than 3 seconds. Okay, any clarifications? Okay, right. Let's get on to the next day. So what we do is we resuscitate her over 6 hours by giving IV crystalloids, right? And now see what has happened. So you can see there are 2 red lines there, day 4. Well, upper red line is when we begin to resuscitate the patient with crystalloids. That is when I say that she is having leakage and she is having hypotensive shock. PCV is 46, platelet count is 40 with effusion. So we start resuscitating her with crystalloids. Then after giving 6 hours, then we have the second line of investigations, PCV 42, platelet count 15,000. She has BP of 80/70, heart rate 120, CRT 3 seconds, effusion plus, ascites plus. What is the current status?
So she may be bleeding right now because hemoglobin is also low, PCV is also reducing with the platelet count 15.
That is right, definitely. Yeah, you can clearly see that there's a very clear drop in the PCV, more than what you would expect for the correction from fluids. Of course, there was a hemoconcentration earlier, 46%, and that is hemoconcentration because of leakage, and we gave fluids for 6 hours, so that 46 will become reduced because of that. But, for it to come down to 42 is very worrying. And also remember, in spite of giving the fluids, right, BP has dropped further, heart rate has risen further, and the refill time has also grown to be more than 3 seconds. So she continues to be in hypotensive shock. Now, this is the reason why we say when you have given fluids to correct a shock, don't just keep giving fluids, check the PCV again. If the patient is responding, okay, you can reduce the fluids and be happy. But if the patient is not responding to the fluid boluses that you are giving, always recheck. Has the patient started to bleed? And one of the most important things that we have to do in that rechecking is to check the Paxil volume. So now we resuscitate for 6 hours and still we find the patient is in hypotensive shock because of 80, pulse rate 120, CRT 3. So, this is basically what you call shock, which is not responding to IV crystalloids. We have given him enough fluid, so much so she has got effusions and ascites because of IV fluids. So why is she still in hypotensive shock? Obviously, there's something more than leakage. So let's check the Paxil volume. And the PCV has gone down from 46 to 42. So we are very safe to assume there's some occult bleeding going on. So this is a case of leak plus bleed, because leak is there. Effusion, ascites, all that is there. Plus there's also bleed because crystalloids have not corrected the shock, and the PCV is much too low, 42, compared to the like after correction of the leakage, the PCV should not drop so much. So this is a case of leak plus bleed. Any questions or clarifications? Do you understand that? Anyone wants any clarifications? Okay, right. So so that's basically another important lesson here is, like sometimes we do this as a diagnostic test also. When the patient is in shock and we are not very sure whether it is leak plus bleed, we give a bolus and then recheck the PCV and then try to see if the patient is responding to the bolus clinically, as well as whether the PCV drop is too much. If the PCV drop during correction of the bolus correction is like something like 4 or so, we generally assume that there's an occult bleed going on. And like that's a very important thing. It's almost like a diagnostic test. We say, let's give a bolus and see what happens with the PCV. So the PCV is very useful. After the bolus, you must repeat the PCV and see where we stand. If the PCV is a healthy PCV, that's fine. Normally, we like a PCV which is slightly higher than normal. Then that means they are having enough red cells. Okay. Any questions? Okay, then I think that's basically what I wanted to share with you.